Hello, Dr. Leijten. Thank you for joining me today in the section Interviews with Clinicians of the Dutch Brain Olympiad 2022. You're a neurologist. Could you tell us something more about your field of expertise?
Yeah, well, I'm a neurologist and I am specialized in people with epilepsy, which is a brain disorder and a very frequent one. So it's estimated that between 0.5% and 1% of the world population suffers from epilepsy. When this epilepsy is severe and doesn't respond to medication, patients might come to me with the question of if epilepsy surgery may be an alternative therapy that will solve the epilepsy. And this is my field of expertise.
So that being said, could you tell us more about the type of patients that you're seeing on a daily basis?
Yeah, so when you take the Netherlands, there are between 80,000 and 100,000 of patients with epilepsy, and they are all first treated with drugs, anti-epileptic drugs. We have a number of them, around 20 anti-epileptic drugs, all different. But somehow some of these patients don't respond to any drug. Actually, if you've tried 3 drugs, no matter what type of drug, and you still have seizures, there is a large likelihood that you won't respond to the other 17 drugs either. So that's a pity. It seems as if 1/4 to 1/3 of all epilepsy patients belong to that category. So you give them drugs, they still have seizures, and seizures are very bothersome. So people want to get rid of it. And when there is an indication that the seizures arise from a specific part of the brain, then epilepsy surgery may be an option.
And what are sort of the most common symptoms that the patients with epilepsy experience?
Yeah, most people, when they think about epilepsy, think of the grand seizures, the tonic-clonic seizures with people falling to the ground, stiffening and shaking, making large jerks with their limbs. And of course, they are unconscious at that moment. And this is very impressive. You really think that people will die or something. It's really very frightening to look at. But that's not the only type of seizure. Actually, seizures can be very small. They can be limited to a feeling in your thumb. A kind of tingling in your thumb can even be a seizure. And of course, anything in between. Most people that I see have seizures with impairment of consciousness. So they are, during the seizures, they don't know what they do. They behave very strangely. But on the other hand, they may not have this large tonic-clonic seizures. They may be confused during a few minutes and show some strange movements or act very odd. And this is, of course, less well known to most people, that this also may be an expression of an epileptic seizure, depending on where in the brain it arises. So every part of the brain producing a focal epilepsy will have other symptoms. And the other way around is also true. If you see what happens during a seizure, you can make an educated guess about what part of the brain is involved.
And what sort of percentage of patients experiencing these mild epileptic seizures occurs versus these very strong tonic-clonic epileptic seizures?
Well, they are the majority of seizures are focal seizures, and usually patients have these focal seizures, and once every now and then it will go into a larger tonic-clonic seizure. Because if you take drugs, I won't say that they don't do anything. They usually take away the tonic-clonic seizures first, but then you might end up with the smaller seizures and they won't respond. This is a picture that we often see.
And could you tell us something more about how patients are being diagnosed with the epilepsy, and especially if you could focus on what are the most important criteria that you measure?
Yeah, well, it is a clinical diagnosis. So we see patterns in this group of patients. And when you hear a story, it may be so typical that I can say, well, this is epilepsy, no doubt. And so this is the judgment of the clinician. And we are helped by, for instance, EEG. Thereby you measure potential distributions over the head. And typically, when a patient doesn't have a seizure, he still may have signs of epilepsy in the EEG. And this is this is the most helpful thing you can do, because, of course, even if a patient has 3 seizures a week, the likelihood that you will see one in your outpatient clinic is very low. So usually you don't see this, the seizure itself. You have a story and you have the EEG, and fortunately the EEG doesn't depend on seizures. And then of course you have MRI or neuroimaging techniques that may reveal abnormalities, and when they coincide with what you think should be the region of the brain that's involved, this of course is a strong help, and it confirms you that you are right.
And which region of the brain is most commonly affected when it comes to epilepsy?
We have lobes in the brain, so areas: the frontal lobe, the occipital lobe, the temporal lobe, parietal lobe, and they all have a certain size, and depending on the size is also the odds that seizures arise there. So I think most of the seizures might be frontal lobe seizures because the frontal lobe is the largest, and then you have the temporal lobe seizures that are often diagnosed, especially because the temporal lobe is a kind of peninsula in the brain. It is a kind of confined area, especially when you compare it to the other brain regions, a highly intricate network. The temporal lobe stands a little bit alone, which makes it easier to decide if a seizure comes from the temporal lobe than anything outside the temporal lobe. So we have a bias towards temporal lobe epilepsy because it's easier to diagnose. But this is not because they are the most frequent seizures. I think they are, frontal lobe seizures may even be more prevalent, but they are much more difficult to diagnose.
Now that you mentioned the underlying causes, could you tell us something more about them, and also what are the risk factors for developing epilepsy?
Yeah, so broadly speaking, you have 2 types of epilepsy: the generalized epilepsy, for instance, childhood absence epilepsy. Most people know these absences, short lapses of unconsciousness, but they're very short and they're in young children. This is a generalized epilepsy, which is considered genetic. So somewhere the brain is eager to get you into the seizure, and it's because something is wrong with your internal mechanisms throughout. What I'm interested in is focal epilepsy. That's the majority of the epilepsies. It's around 3/4 of all epilepsies. They arise from a specific part in the brain that may be damaged due to trauma or to ischemia or anything really. But as I said, sometimes the epilepsy just happens. The MRI is entirely normal, and people were behaving normally until they suddenly got their epilepsy. And we think that the majority of these people have very small areas in the brain that during development somehow got out of order. And what you must think about is, for instance, the outer layers of the brain have not been exactly right on the right spot. So in between normal pyramidal cells, neurons, there are neurons that have a different organization or are in a different network very locally, and they produce epilepsy, and that's the only thing they produce. And you only find this when you do surgery, analyze the tissue, and see that there are very subtle abnormalities there. And this explains as well why you didn't see it on MRI, because MRI is no microscope. So you understand that's very difficult to see. The neurosurgeon won't see it either.
And what about the risk factors?
Well, clearly, risk factors are a family history. Somehow there is a propensity towards epilepsy in certain families. But the majority of risk factors is related to old age, such as having suffered dementia, or having suffered a stroke, or having suffered a trauma, or any chronic disease. So this is clearly the majority of risk factors. And in most young people, you don't find a good explanation. And we think it is in the microstructure of some brain area, but sometimes we don't find it with microscopic examination either. And then you're left with a question mark.
Yeah. Lastly, I would like for you to tell us something more about the currently available treatment options for preventing or treating the progression of epilepsy.
Yeah, so this is a challenge because really, if you want to cure a focal epilepsy, you have to do surgery, take away the brain part that is affected, and then you may end up with someone without seizures, without medication, cured in a way. But this is the ideal case scenario. But the majority of people with epilepsy are not cured. They continue medication, and if medication is successful, they continue with it. For very long times, 10 or 40 years is no exception. Of course, there are a few new therapies. I'm myself am involved in a therapy of cortical stimulation. So you know where the seizures arise. You introduce electrodes in the brain that remain there permanently and are connected to a pacemaker, which delivers a current once a seizure is recorded. This is something new. There are certain diets, so people leaving out the carbohydrates in their menu, and this helps in children. It's called the ketogenic diet. It's a kind of very strict Atkins diet, and this certainly helps in certain cases of young children. And there are new therapies that are similar to surgery with laser therapy in the brain, using laser-guided surgery, and no doubt other treatments will arise. And I shouldn't forget one prospect, and that is, once you could predict seizures, perhaps a lot of people won't take any medication or any therapy anymore, because the tricky thing about epilepsy, of course, is that seizures arise spontaneously and you don't know when. And this makes life very uncertain. So if you have epilepsy, you could have a seizure during an interview like this, or just when you go shopping in the supermarket. And this is frightening, because you know you're not yourself, you're acting strangely, people will look at you and think you're mad or something. And this is very embarrassing. And people sometimes avoid going to the supermarket for this reason. And of course, if you could have a kind of watch that tells you you will have a seizure in an hour, or the other way around, that you won't have a seizure the next hour, many people would think, well, let the seizures come. If I can only rely on some kind of prediction, I think most people would say, okay, I don't like this medication. They all have side effects. So I will take my seizures if I know when they come. And this is a challenge. This is, I think, the major challenge for the next decade. How do we predict that patients will have a seizure?
Well, now that you mentioned predictability of epileptic seizures, are there maybe any known triggers, external triggers that were recognized as the ones who can be 100% related to trigger the episode?
Well, 100%, I don't think so, but there are certainly individual patients who have very specific triggers for their epileptic seizures. For instance, light flashes that may induce seizures is a very well-known one, but there are others. We know that seizure patterns, so when they recur, at what time they recur, sometimes there's a pattern in that, circadian or over courses of weeks or months or even years. You have peaks in that have some predictability. So there is some underlying behavior of this. And of course, stress is a well-known predictor. But on the other hand, it's very difficult to use that knowledge, because, what is stress? When do you know that you have stress? Can you avoid stress? Can you treat stress immediately? No. But there are certain signs, biomarkers of stress in the saliva. Cortisone, for instance, is related to a seizure occurrence, definitely, but not 100%, certainly not.
Okay, thank you so much, Dr. Leijten, for joining me here today, and thank you for sharing a glimpse of your knowledge about the epilepsy.
No, I wish everyone much success.